And so we're going to talk about a little bit of what we all see on a daily basis of maybe recommending or thinking about recommending a nutraceutical and applying that in our practice, but then having patients say, well, oh, I already take omega-3s, or I already take that fish oil supplement that I get at Costco, and immediately meeting resistance and saying, well, okay, I guess they're already trying that. Let's move on to the next thing I want to recommend for them. And we're doing ourselves and our patients particularly a disservice if we just let it go at that, without recognizing the distinctions that HydroEye has over a lot of these other nutraceutical or supplements that we very loosely call megas or fish oils and things of that sort. So we'll talk a little bit about specifically the role that HydroEye has played in my practice and sort of the practice protocols that we have leading up to the main focus of my practice, which is refractive cataract surgery and corneal refractive surgery. But as a necessity, we've really had to specialize in treating ocular surface disease before we ever pick up our scalpel or femtosecond laser. So we're going to talk a little bit about, as a transition, interventional mindset. And this is something that I've seen in my own practice over the last 10 years. I'm seeing it now not only in ocular surface disease, but in refractive surgery, in glaucoma surgery, and glaucoma practice. And I think it's a really key shift that we're seeing that's going to really benefit patients, number one, but also our practices and our entire industry, number two. And so that's why I'm going to be really excited to talk about my whole lengthy experience with IPL therapy for MGD and ocular rosacea that we see a lot of here in the Sun Belt and in Florida particularly. And we'll talk about how IPL technology and therapy has really transformed my practice over the years, and why specifically I really do like the EI device, and why I've kind of landed almost by accident on the EI device. So we'll talk first about HydroEye and why all the omegas, as we bandy around that term, are not the same. And so oftentimes we hear patients talk about fish oils and dietary supplements. And why is HydroEye really different? Well, all fish oils are certainly not the same, as we know that from intuitively. But neither are all the supplements that claim to be high in omega-3s and anti-inflammatories, because a lot of these are sourced from maybe some subpar sources like farm-raised fish. And they may not have the same anti-inflammatory properties that HydroEye has, as we'll see. So what is the difference? And why do I prescribe HydroEye preferentially to my patients? And why do we have it in our office for immediate dispensing as the patient leaves the office, which certainly helps with compliance when they leave the office with the product you're recommending? Well, number one, first and foremost, is we're all evidence-based clinicians, and we want to ground our decision-making in science-based decisions, no pun intended, with science-based health. But HydroEye is a patented, clinically tested, truly clinically tested oral formula that provides continuous relief in the form of this unique GLA, or gamma-linolenic acid. This is an omega-6 family omega acid or essential fatty acid. And its potency and effect is backed by no less than 8 clinical trials specifically looking at GLA and HydroEye. This is a GLA that's not found in our diets. You can't get it in flaxseed or fish oils. And HydroEye also uniquely provides some other key omegas and nutrient cofactors that support this anti-inflammatory property and action. And so we see that it stimulates tear production, it eases inflammation. Again, this is all evidence-based statements here, which you cannot say about other nutraceuticals that are in the industry. It is effective because largely there's so much overlap in ocular surface diseases and types. It's very rare that we would see a patient with just evaporative or MGD dry eye, or a patient with just aqueous tear deficiency. And so this kind of anti-inflammatory action is really applicable to all forms of ocular surface disease because the root common denominator is inflammation, as we know. And so I also like it, and patients like it, because the guarantee of 60 days or your money back really is timed to match the rate of efficacy, where 80% or 85% of users will begin to see a difference when they use it on label. And so let's talk a little bit about what patients perceive as the benefits, as opposed to many of the other supplements that might be out there in the market. Number one, even though this is a nutraceutical, it's about a capsule that's 40% smaller than the typical fish oil capsules, better tolerability, fewer side effects that are unpleasant. We know that it is a specialized formula that we'll delve in a moment. It comes at a much more moderate price compared to some other nutraceuticals in the market, and it's backed by this guarantee. The reason I like it is the same reason that patients like it. It's effective and it's science-based. It is clinically backed and evidence-based. And so this is just a smattering of some of the studies and references to randomized controlled clinical trials that actually look for the benefit. Unlike many of the nutraceuticals in a very sort of Wild West arena of nutritional supplements that are poorly regulated, this one has actually been scientifically studied in peer-reviewed journals in ophthalmology. And none other than my good friend and colleague, John Shepard, and who's someone who I would consider a mentor in ocular surface disease, pharmacology, and pharmacokinetics. Steve Flugfelder published this pinnacle paper on HydroEye that validated its clinical effects. Just to summarize those, a significant improvement in irritation symptoms, symptom scores versus placebo. So we've got symptoms, better corneal smoothness, we've got signs, and significantly lowered measured levels of inflammatory markers. So we've got signs, symptoms, and quantitative reduction of inflammation versus placebo on a double-blinded, randomized controlled clinical trial. What is the source of this magic sauce, the GLA, the gamma-linolenic acid? It is not necessarily a fish-derived source. It is black currant seed oil, and also evening primrose and borage seed oils. And let's look for a moment at how this all works. Now, I have to admit a mistake. When Cynthia asked me to speak initially a couple months ago, I thought this was going to be a 3-hour seminar, and I was going to spend the balance of the next 2.5 hours dissecting this slide in detail to remind all of you of what Biochemistry 101 was. Now that I know that we don't have the time to do that, I'm going to fly through this and just kind of give you the high points here. Number one, we realized that alpha-linoleic acid is an omega-3, and linoleic acid is an omega-6 family. These two are commonly found in our diets and in nutritional supplements that are out there, but they are inefficiently used by the human body, and they don't directly affect inflammation as much as claims to the contrary might be. Whereas we have GLA, gamma-linolenic acid, and EPA, another omega, and EPA actually leads to the production of good prostaglandins. So contrary to what we may all think, prostaglandins is not a bad word. There are good prostaglandins and bad prostaglandins. And so EPA contributes to the production of these good prostaglandins that are anti-inflammatory. And there's a component of GLA that leads to also good prostaglandins that are anti-inflammatory. But as I mentioned earlier, gamma-linolenic acid is an omega-6. And we've all heard, well, I thought omega-6s were pro-inflammatory. And that is true insofar as the human diet, and particularly a Western diet, leads to the ingestion of certain linoleic acids that lead to the production of arachidonic acid, which, if we remember, is at the root or the top of the inflammatory cascade, and that leads to bad prostaglandins. But GLA is unique because it really drives and favors this anti-inflammatory pathway. And then we have the added help of this cofactor EPA that blocks the conversion of GLA to DGLA and the arachidonic acid pathway, and instead diverts that to the good prostaglandin. So basically, take-home message is GLA good, EPA even better, and this is anti-inflammatory. And that's what is the secret sauce of HydroEye in a 2-second dissertation here. GLA is the precursor of this potent anti-inflammatory prostaglandin PGE1, and PGE1 is found in normal tears, normal lacrimal gland, normal conjunctiva. And so that's the good prostaglandin we want to normalize and promote. And that's what GLA does. But in order to promote the production of GLE1, the good prostaglandin, we also need these other cofactors, which is why HydroEye includes them. The B6, the magnesium, the vitamin C, all of these are already in the HydroEye formulation. And so it's all sort of built in as one-stop shopping. And so it's able to be utilized by the human body in this anti-inflammatory sense. I want to point out one thing on this. We know this anti-inflammatory property is not just beneficial to dry eyes, but a lot of other immunologically driven processes from RA to IBD and even diabetic retinopathy, as some studies have shown. But the thing I want to point out here is that, again, all omegas are not the same. All nutritional supplements are not the same. When you look at some of these omegas that are out there that patients might be taking already, they contain 2,000 to 3,000 milligrams of omega-3s in order to have any measurable effect. And one might look at a bottle of HydroEye and say, well, gosh, it only has 235 of this omega GLA. And so why is that? Well, because the GLA is so much more efficiently used and so much more potently anti-inflammatory that it doesn't require a whole lot. And so there's 2 different inflammatory markers that are going to be significantly reduced in these key pivotal trials. Now, kind of waxing philosophically here, we have to, as physicians and clinicians, recognize that our recommendations have to evolve with the times. And we have to kind of stay ahead of where patients are and make sure we're making good recommendations. And so our treatment philosophies for ocular surface disease and dry eye have really changed a lot. I think when I was in residency, dry eye was almost like the polymyalgia of ophthalmology. It was almost a psychiatric diagnosis, and it was sort of poo-pooed. You know, here's some sample tears, get out of my office, and come back in 6 months, even more miserable. And so this was my attempt back in 2006 or so, right when I was finishing fellowship at Wilmer, to try to summarize everything that Essen Akpeck, the professor in immunology, the professor of rheumatology, and the professor of ophthalmology taught me about ocular surface disease. And I tried to make some sense of this for a private practice, clinical practice, high volume. And this is what I came up with. And so I wanted to kind of share with you the diluted, distilled wisdom of Essen Akpeck, Steve Flugfelder, John Shepard, Cynthia Matosian, and this is what I've kind of distilled from all of these wonderful mentors and resources. And this is what I employ in my practice every day. To boil it down, I'll direct your attention to the bottom right, where you're going to see that after basic screening, basic workup, speed questionnaire or OSDI questionnaire, we're directing our optometrists, our PAs, everyone that's at the bottom of the pyramid, triaging ocular surface disease patients that come to our center for ocular surface disease. They're instructed to start every single patient on some kind of lubricant, MIBO or Retain MGD, a Bruder mask, so we're addressing some of the MGD component. HydroEye, we're addressing the nutraceutical component, working from the outside in and the inside out. We're addressing the immunomodulatory therapy with whatever flavor of choice. And we're also taking an interventional approach with Lacrophil. All 5 of these things are first-line therapy for everyone. The only caution is that because HydroEye does have such a potent effect, I always recommend patients that are on certain blood thinners to consult with their primary care physician just so that they don't become hypo or hyper anticoagulated. I want to focus also and share with you a shift, a 180 shift in our mindset of how we work up patients and how we go through our decision making from diagnosis to treatment. I've actually flipped this in my mind for the last 17 years of practice. We already know the answers to the question. And so we just have to, almost like Jeopardy, we have to kind of ask the right question, knowing what the answer is. It's a little bit backwards, but here's what I mean by that. Most of the time, we go through a very diagnosis focused exam, and we're looking for clinical elements and findings. And then we assimilate all of that in our mind. We go through the whole history, taking the exam, and then we come up with a diagnosis. And then we say, well, what treatments am I going to use to take care of this diagnosis? I think about it in exactly the opposite direction because I already know what treatments we have. I already know what the lowest common denominator is, inflammation, and I know what tools we have in our toolbox. And so all I'm doing is doing a treatment focused exam, looking at the patient for confirmatory answers. And I'm saying, do they have findings that support this treatment? Yes, great. We're going to do this. We're going to do this. We're going to do this. No, they don't have any blepharitis. They don't have MGD. Well, then we don't really need to do these things. We're going to focus more on perhaps maybe the mechanical side of dry eye and address their conjunctival chalasis with a different surgical therapy or intervention. And so that kind of thinking, that somewhat backwards way of thinking, really makes the whole clinical process with a patient far more efficient. And it allows the patient to then focus on what are we doing? What is different than the things I've tried before that haven't worked? And it allows the patient to psychologically release and let go of all the things that they've tried that they want to tell us about that haven't worked, and now focus in a forward-looking way on what is going to work and why. And so then we can kind of transition the conversation to a forward-looking way. I want to highlight this way of thinking with cases that were shared with us by another good friend and mentor and expert in ocular surface, Laura Perriman, from the West Coast. And she shares a case of this 51-year-old executive with hypercholesterolemia, burning some symptoms and sensations, foreign body sensation at the end of a very long computer day, as we all have nowadays. Speed questionnaire and score shows probably mild dry eye. Osmolarity certainly shows some warning signs of ocular surface disease. Matrix metalloprotease 9 testing and inflammatory testing is positive. So this patient is pregnant with dry eye. Their tear breakup time is dramatically reduced. They've got signs, symptoms. And as is common, as I said, this patient's already on omega-3s. They think they're treating something. And so we have to kind of surpass that and get past a lot of the disillusionment, the disinformation about nutritional supplements, nutraceuticals, and really implore our patients to understand that we understand the difference that HydroEye makes scientifically. So this patient was recommended to take HydroEye, a topical immunomodulatory therapy, some form of cyclosporin, a short course of steroids, all things that I would do as well, and follow up in about 8 weeks for in-office thermal pulsation of some form. So an interventional treatment. I love it. This is great. Well, in this particular case, the holiday season, the patient's work life got in the way, and the only thing that they actually were compliant with was the HydroEye. And so, as it turns out, as you'll see in the pictures on the right side, they were pregnant with dry eye before, and now if you look at the bottom, their left eye has gone negative. They're no longer pregnant with dry eye, as the test shows you. So the inflammatory markers have decreased. Their osmolarity index has decreased, as you see below. Their speed questionnaire, their symptoms levels have gone down to 6, which is normal, and all with just this intervention of HydroEye for what makes, let's say, 2 months, really, over the New Year holidays. So That has had a profound effect on my thinking when it comes to my focus of the practice in terms of refractive cataract surgery. If this works so well for our dry eye patients, most of our cataract patients, the number one reason we miss results and miss outcomes and have refractive surprises is not all of these technologies. The femtosecond lasers are great, LRIs are great, astigmatism correction has really become an art and a science. We've got all of these wonderful multifocal, trifocal, accommodating lenses, toric lenses, EDOF lenses. These are all great and fun and sexy to talk about. We spend very little time talking about biometry and optimizing the biometry, and even less time, unfortunately, talking about optimization of the surface. And so, in a sense, I think we're all guilty of this. We're all very, very smart, talented people, but we're all kind of students of the Midvale School for the Gifted at the same time. We can kind of miss the big picture if we're missing ocular surface optimization before we pick up our laser or scalpel. So HydroEye has become integrated into my cataract surgery thinking, my preoperative thinking. The last thing I want to do is mention ocular surface disease to a patient who's already had surgery, is dissatisfied with the result because they've got dry eye, they've got ocular surface instability, tear film instability that's leading to visual fluctuations. And now I'm making the excuse of, oh, it's your dry eye. So there's a powerful psychological messaging that goes along with prescribing HydroEye, even though we know it's going to take some time to work and some level of compliance from the patient. But there's a powerful messaging prescribing this before surgery to say, I am on your side. I want you to get the best outcome. You've got to take a role in your own care and helping me get to that outcome by optimizing the surface and treating the dry eye before. And that's going to allow us to get better biometry, better measurements, better planning, and a better outcome for you. And that way, if they do have some visual disturbances and need enhancement, need further treatment for their dry eye, they're already psychologically primed to know that that was an issue preoperatively. It's part of their expectations, not part of their perceived complications. So this has become a part of my cataract optimization process. This is a 37-year-old patient in this case, but I'm going to pretend and ask you to pretend for the moment that this was a cataract patient because it kind of follows in the same line. This is a patient that's been diagnosed with dry eye. HydroEye was prescribed in addition to their topical therapies, including cyclosporin in this case again. Measurements were taken before and after with eye trace. So we have some aberrometry, wavefront analysis, as well as topography. And so if we look at the pre-treatment images, we see what pops out here is a lot of irregular astigmatism, superior inferior difference. And if you were to plan cataract surgery, again, pretending this was a cataract patient or refractive patient, we might be thinking, well, gosh, I'm going to need to treat 2.5 diopters of astigmatism. It looks fairly regular, at least in terms of axis here at 80. Let's go ahead and put a toric lens in, maybe a T 2.5, maybe a T5, T6, or T7. And so this would lead to a very unhappy patient because look at what happens after treatment with HydroEye. We've improved the ocular surface, we've improved the meibum secretions, we've improved tear film quality with this potent anti-inflammatory effect. And that 2.5 diopters of irregular astigmatism that may have led you to put in a toric that would have led to a very unhappy patient, all of that astigmatism disappeared. We went down to 0.6, and now we're talking about a lot of different, certainly non-toric IOLs in my thinking. And so this is a near miss in my book. And so really, really great to see that effect with just HydroEye alone and supplemented with normal topical therapies. And so we're seeing 50% reduction in all three higher order aberrations, the coma, the trefoil, the spherical aberration. Again, that's going to change my thinking in terms of what lens is best for this patient. And so it's good for the patient. It's good for the practice. That's the win-win we're looking for. And so I can't really emphasize this enough. This is the kind of win-win we should all be looking for. to be able to provide something to the patient as they walk out the door. We have a little preoperative kit that includes the HydroEye, a Bruder mask, some sample tiers like Refresh Mega 3 or Retain MGD, and they're walking out with that. It's got their post-operative instructions, and it's all in a little tidy promotional kit with our logo on it. And so every patient basically leaves with that, and that helps with compliance. You can't expect patients to go and source these things themselves. Cynthia, I think I've got some questions that I should probably answer.
Yes.
Maybe this is a good time.
This is a great time. First, that was a wonderful presentation, Neel. Thank you.
My
I
pleasure.
too have seen so many cases of this pseudo astigmatism that looks real. And you
Yeah.
can very easily be fooled in either planning a toric or an LRI or some other astigmatism reducing procedure when it's really the tear surface that's creating that. Unless you're astutely looking for it and be kind of hyper alert to diagnose it properly, you can end up really doing the patient a disservice very easily. So I'm a big proponent, like you are, of looking for dry eye actively and actually assuming everybody has dry eye until proven otherwise, who are on your cataract consult schedule, and then pre-treating with a HydroEye to help that kind of catapult the anti-inflammatory process so that you end up with better surgical outcomes. It's so important.
100%
So
agree, and I really do echo that, and I think it's worth saying again. It's almost become the rule rather than the exception for our
exactly.
cataract patients to have dry eye, and so we should almost assume that that's going to be the case until proven otherwise.
Can't agree with you more. One question we had was if GLA comes from black currants, like you showed in your earlier slides, is HydroEye vegetarian?
Good question. So Zach might want to pipe in here, but it is not completely because there are other omegas that are supplementing. And so there are some fish products that are included that support the GLA and its anti-inflammatory properties. Zach, do you want to expound upon that?
Yeah, that's absolutely right, Neil. There's a gelatin capsule as well. So while it's not vegan or vegetarian, it has sort of a higher content of sort of plant-based ingredients, and the plant source probably, helps with the less fish smell and that kind of thing.
Yeah.
Great. That was a great
Patients,
question because
yeah, and
patients ask that.
yeah, I have noticed that patients who have already been on various types of fish oil supplements, when we switch them over to HydroEye, they say, "Oh, actually, I've noticed that this doesn't cause me to belch and feel like I've got that fishy aftertaste, several hours after I've taken it." And so there is less of a profile, but it's not vegan or vegetarian, unfortunately.
Neil, one other question that's come up is you mentioned that sometimes patients come to you on the generic brands of omega 3s with some of these side effects and not the kind of therapeutic effect that we're looking for. So it's going to take some time to explain to the patient why they need to discontinue that and start HydroEye. Who does that conversation with your patients?
I have that conversation with patients. And so this is the way I shorten that conversation. It goes back to something I learned from reading a book by Chris Voss called Never Split the Difference. Chris Voss was the lead hostage negotiator for the FBI. And he talks about how every negotiation really needs to start with getting a no, not a yes, but a no. And so the way I phrase certain questions, prodding questions, targeted questions to dry eye patients in particular, and even cataract patients for that matter, is phrased in a way that's specifically designed to elicit a no. I'll give you an example. The reason you, Mrs. Smith, are here is because you think you have dry eyes. Of all the things that you've tried, I see a list here of all the things you've tried. Have those things worked? And then I give a pause for dramatic effect. And then I answer the question for Mrs. Smith. And I say, well, I guess you wouldn't be here, I suppose, if those things had worked. And that immediately lets them let go of all the things that they've tried because they're sitting there because they're looking for something more, not more of the same. They're looking for something different, something that is going to work. And I think it's fairly simple. If there is any reluctance or resistance to change what they've been doing after that, to simply say, look, there's a lot of supplements out there, but it's a fairly poorly regulated space. A lot of these supplements have not undergone the scientific study that this one has. And this is the reason why I carry this one in our office, because it has been scientifically studied for its beneficial effects for dry eye patients. It's not an end all be all, though the two cases that I just shared kind of defy that. But it is a part and a tool that we're going to use together with other tools to get you actually some relief where other things have not worked. And I think it's a fairly simple conversation, but I have it myself because patients are ultimately looking to their doctor, their clinician, for that recommendation and that guidance.